Thank you very much. Thanks for the invitation to be back here. I'll be talking today about hybrid revascularization, which is becoming quite a useful tool and strategy for treating patients with multi-level disease. So we hear a lot about the no option for treatment critical leg ischemia, and it's becoming an excuse for us not to do anything or maybe offer the patient a major amputation. The problem with the definition of no option for treatment critical leg ischemia, it's talking about no option for treatment either using an endovascular approach or an open surgical approach. But I think this is where the problem with the definition, it's either or. Of course, if you're lucky, you can get one of the new treatments, stem cell research or growth factor treatment. So again, the no option for treatment critical leg ischemia, or maybe even better, critical foot ischemia, because in the patients that we treat, the problem is the foot. This is where the tissue loss is, and this is where most of the peripheral vascular disease is, in the crural and the pedal vessels. So the question is where the treatment level should be. Should it be up in the thigh or maybe all the way down to the foot level itself? So the options we have for this sort of critical foot or critical leg ischemia, it's either going to be a pedal bypass to get the blood flow all the way down in a straight line flow, or if we're good enough, we can do the loop plantar angioplasty, which is becoming quite a standard procedure in most units now. Where I work, we have the majority of our patients treated with an endovascular approach. Contrary to what people think, that we're doing bypasses for all our patients. We only offer bypasses for about 30% of our patients. But the interesting part of what we're doing now is that hybrid part that we are offering the treatment both endo and open together. And although it's about 15% when I last look at it, I'm sure the percentage is going up as we develop more of these strategies. So our definition for the hybrid revascularization, it's a planned combined procedure for angioplasty or bypass, either synchronously or metachronously, so either done in one stage or done in more than one stage. And we think this is an ideal treatment for the multi-level disease for the patients that we see, especially patients with diabetes and severe critical leg ischemia. Our philosophy is that the shorter the graft is, the less joints that you cross, then the better the outcome for these patients. We divide our hybrid procedures to hybrid 1, 2, and 3, depending what we do first. So if in hybrid 1, we do the inflow, and then we do the bypass. In the hybrid 2, we do the bypass, and then we can angioplasty through the bypass down to the foot level with an angioplasty, or we can do angioplasty, bypass, angioplasty, which is the hybrid 3. So this is what we're talking about, hybrid 1 angioplasty stage. You can see there's some significant SFA popliteal disease. We put our balloons in. We used to use lots of drug-eluting balloons in these patients and open up all the way up to the popliteal artery. And then we can do a short graft from the popliteal artery either to the dorsalis pedis or the posterior artery, depending on the angiosome, of course, and depending also the availability of arteries. So my ideal bypass is something that I will take from the popliteal artery, taking a common femoral bypass all the way to the dorsalis pedis. In my opinion, it's I think it's doable if you've got enough venous conduit, but I'm not sure about the patency rate and the quality of the bypass. Whereas in the hybrid 2, we do the bypass first, and then through the bypass, we can offer an angioplasty to the crural vessels, depending how far we need to go. And this, again, can be done either in one stage or 2 stages. We heard about the European guidelines earlier when it comes to antithrombotic and antiplatelet therapy. And this is the same guidelines published in 2018. And at the bottom on the left, they're talking about the lower extremity arterial disease. And also they're talking about either angioplasty or bypass. They were a bit biased towards bypass if the disease is sort of infragenicular level, as long as, of course, you have a good venous conduit. But they didn't mention any hybrid treatment at this level of disease. Hani is sitting in the audience today. He did a very elaborative review about hybrid procedures. he divided the hybrid procedures into about 3, 4, or 4 categories depending on the procedure performed. We're all familiar with the femoral endarterectomy and on-table iliac angioplasty. We do it quite regularly, plus or minus stenting, of course. Or the iliac artery stenting, and then we can do a crossover fem-fem bypass. We do this also as a synchronous or one-stage procedure. And then also there is the infrainguinal hybrid procedures, either an iliac angioplasty and a bypass, or the infrainguinal hybrid procedures with all the mixtures that come with it. And I think it was a very good review looking at all the possible procedures that could be offered. And I was very pleased to see the bottom sentence added in the conclusion that although the 2 modalities were quite blurred and people were arguing which should be used, now the 2 modalities are actually fusing together, merging together to give us a third option, which in my opinion is one of the best options for multi-level disease. This is a publication from 2010. They had a very large volume of cases in this publication looking at the complex revascularization hybrid technique. Although the hybrid cases were about 108 cases, and they showed that these cases where they done hybrid procedures, they had very good outcomes, even better when they used a single modality. And I agree with this sort of policy. This is a recent paper published 2018 looking into hybrid procedures. They've divided the patients. It wasn't a huge series. It was 61 patients with critical leg ischemia. They divided them either to a straight line flow, and they called this complete revascularization, or an incomplete revascularization when you've done 1 level only rather than the 3 or 2 levels needed. And we're talking about critical leg ischemia here. And of course, they discovered that the patient who had full revascularization using a hybrid technique had better outcome than the patient who had incomplete revascularization. So they confirmed that hybrid technique works very well. And of course, the old standard teaching that a straight line flow is what you need to treat patients with critical leg ischemia is true. We looked into our data, hybrid procedures for critical leg ischemia. We only included critical leg ischemia. And we looked into all patients who had either tissue loss or rest pain. We looked into how we've done our infrainguinal reconstruction, and we followed all our patients with a graft surveillance program. We had 124 patients and with 124 infrainguinal bypasses, and the minimal follow-up in this group was 90 days. In the hybrid 1, we've done 88 cases. In the hybrid 2, we've done 24 cases, and hybrid 3, only 12 cases. So as you can see, the majority of our patients were hybrid 1. You do the angioplasty first, and then the bypass. Our patients are elderly patients, so the median age was 72. The majority of them were men, and there was a significant number of patients who were diabetic, and also a significant number of patients who were renal failure patients, about a third of them. By the way, this is the standard sort of mix of patients that we get in our unit, probably across the UK. So we've done, for the bypasses, we took the proximal anastomosis. As you can see, the majority of these patients were from the popliteal artery, either above or below. Very, very few patients were treated by a bypass from the common femoral artery, and about 20% of the patients we took the bypass from the superficial femoral artery. But the message is that we're trying to take the bypass away from the common femoral as distal as we can. And this is the outflow arteries. Where we've done the anastomosis. The majority of these patients were either anterior tibial or posterior tibial artery. Some of them were dorsalis pedis and plantar arteries. For the hybrid 1 angioplasty, the majority of the angioplasties were done for the SFA. Again, we're trying to go as distal as possible to the popliteal artery to take our proximal anastomosis from. And there was only a few patients from the iliac arteries, but the majority of the angioplasty was done for the SFA. For the hybrid 2 angioplasty, so this is when you've done the bypass and then you go through the bypass to do angioplasties. As you can see, the majority of these patients had either posterior tibial or anterior tibial angioplasty. So the 1-year outcome for this group of patients that we've done, The TLR was 17.7%, so about 18% of the patients required an angioplasty for the same lesion that we have angioplasties before. I was very concerned about taking a bypass from the popliteal artery when we've done an angioplasty. For the SFA, sometimes we even had to put some stents in. And of course the concern was how many times we're going to have to revisit this angioplasty again to keep this graft going. And to our surprise, there was about only 18% of the patients that required a second angioplasty for the same lesion. Our 30-day mortality, we're quite lucky. We didn't have anybody dying in this group. And our 1 year mortality rate was 4.8. This is actually lower than our usual mortality rate. Again, the major amputation rate was only 3%, and the amputation-free survival at 1 year was 92%. This is again the 1 year restenosis, and you can see that 82% of the patients did not require any retreatment of the angioplasty segment that was done prior to the procedure. 4 year amputation-free survival, 50% of the patients were alive with the leg in 4 years' time. We offer lots of graft salvage angioplasties because we put all our patients in graft surveillance program, and you can see about 40% of our patients required an angioplasty for the graft at some stage. This is standard with all our grafts. About 40% of our patients will require an angioplasty. We're quite aggressive treating these patients with salvage angioplasty if needed. And this is the patency rate for these grafts over a year's time, primary, assisted primary, and secondary patency rate. So the conclusion for the study, we showed that the hybrid revascularization offers a quite good, reliable treatment for the multi-level disease, and the 1 year patency rate was quite good, and the most important thing, the TLR was about 18%. Very quickly, I'm going to go through different types of hybrid procedures we do. This is a patient on the left side has got critical leg ischemia with a long segment occlusion, only the perineal artery that's available. On the left side, this patient had a hybrid procedure, a stent, an angioplasty of the SFA, and a bypass going down all the way to the dorsalis pedis. We used the remote endarterectomy loops quite frequently. We did a long segment endarterectomy of the SFA and the popliteal artery, and then you can do a bypass, short bypass to the perineal artery. This patient did not have enough available veins for usage. And again, another patient you can see, they had remote endarterectomy and a bypass all the way down to the dorsalis pedis on the right side. Ultra-hybrid revascularization is something that we're pushing for, so we do our bypass down to the ankle level, and through the bypass, as a one-stage procedure, we open up the arch as much as we can. So in conclusion, Mr. Chairman, ladies and gentlemen, the no option for treatment clitoral leg ischemia is an undefined disease only to justify unnecessary major amputation. Hybrid revascularization, in my opinion, is a fantastic strategy with patients with multi-level disease. And of course, there's enough evidence now to support this as a treatment of choice rather than just angioplasty or bypass alone. Thank you very much.
Thank you, Dr. Hisham, very much for this nice